So having discussed all the basics of the renal chapter, now we go on to the diseases, and that's nephritic and nephrotic syndromes. Before I begin, it's important that we should know the differences between these two entities so that we have clarity over their common symptoms as we'll go forward. So yes, when we are talking about nephrotic versus nephritic, it might sound like a very single alphabet change that we have. But please remember that nephrotic is going to have O. So, oh my God kind of proteinuria. There is a lot of proteinuria there. Whereas nephritic has minimal, mild proteinuria. So what do I mean by that? When we say nephrotic, as I said, oh my God kind of proteinuria. So there is a massive proteinuria and a lipiduria that you notice. Means a lot of lipid in the urine, a lot of protein in the urine is going to go. And what is the definition of massive proteinuria? More than 3.5 grams of protein going out in a 24-hour urine sample. More than 3.5 grams. And what I want you to notice over here, more than 3.5 gram of protein everyone learns. But then you forget to learn the unit. In 24-hour urine output means you will ask the patient for what sample? You are not going to ask the patient for a single urine sample. You are going to ask the patient for a 24-hour urine sample. That is full 1 day. So the instructions given are that you wake up in the morning at 8 a.m. You start collecting urine from 8 a.m. on day 1 up till 8 a.m. on the next day. So the entire 24-hour urine has to be submitted to the lab, and then this entire analysis is done. Okay. So this is, oh my God, means massive proteinuria. Now think logically, if so much of protein has gone out into the urine, what will happen to the levels in the blood? Of course, there is going to be hypoalbuminemia. So all the protein out in the urine, the level in the blood is going to decrease. There is hypoalbuminemia, and that is going to result in edema. So yes, now a very important question comes is that when you are talking about edema, what is the most common cause of swelling or edema in nephrotic? Obviously, I've told you that one of the causes is that the protein levels in the blood are going to be down. That is hypoalbuminemia. But please remember, one of the most common causes is going to be sodium water retention. And this is a question that has come a lot in your medicine chapters. What is the most common cause of edema? And that is going to be salt water or sodium water retention. After that, it is going to be hypoalbuminemia. You know another thing. So what all is going out into the urine? Protein is going out into the urine. Lipid is going out into the urine. Also, another thing going out into the urine is antithrombin 3. So have you wondered that why are these patients having thrombotic events? Why are they having blood clots? Why are they having thrombotic events? Because antithrombin 3, AT3, is going to go out into the urine. And this I'll be telling you a little bit more detail when we go to nephrotics. But for the time being, remember, all of the AT3 is going to go out into the urine. That is why antithrombin, the one which was supposed to stop the clot formation, that stopping factor has gone away. The control has gone away. This means now the patient is going to have a lot of clot formation in the body. Okay, this was about oh my God events, nephrotic. Now let's come to everything mild. Means what kind of proteinuria am I talking about? Mild proteinuria. And what do I mean by mild? Less than 1 gram in how much of urine? Again, I will have to take the 24-hour urine output. So now you know the definition of mild also. Mild means less than 1 gram of protein in a day that's coming out. Moving on, apart from this, patient has HO-HA. That is how we learn it so that it becomes easier later on. H stands for patient is hypertensive. Next, patient is going to have a less urine output, decreased urine output, and that is going to be oliguria. There is H for hematuria. There is blood in the urine. And there is azotemia. What is azotemia? What levels are elevated in the blood when we say person has azotemia? There's an increase in the blood, urea, nitrogen levels. So repeating once again, patient has mild proteinuria and HO-HA. So now look at the 2 urine samples that I've given in front of you, because now as a clinician and as a practicing doctor, you will have to do the analysis by looking at it. This is something which you will get later on from the path lab. But you have to first look at the urine and you should be able to give a tentative diagnosis. So when you start seeing this kind of a cola color urine, you will obviously think of hematuria. If you're thinking of hematuria, you will obviously think of nephritic syndrome because you're getting a lot of blood in the urine, right? So if you see a lot of blood in the urine, you will obviously think of cola color, which you famously call, you will think of nephritic syndrome. On the other hand, if you see a urine sample which is looking like this, it's looking very, very frothy. The patient will also come to you with the description that my urine has a lot of frothiness. In Hindi, it's known as jhaag. So it has a lot of bubbles, it has a lot of froth. If that is the kind of description that is given, this means it is nephrotic. What is frothy or why is it frothy? So much of protein is coming out, so much of fat is coming out. That is what is giving it the frothiness. That is how you differentiate clinically between these two conditions. Having said that, guys, let's begin with them one by one. Let us begin with nephritic syndrome first and foremost. So at least I've done my work, made my work very, very easy. I know that now when I'll be talking about nephritic syndrome, you will have mild proteinuria and you will have HOHA in all the patients. So I don't have to repeat it again and again. I've made my life simple. Let's begin with nephritic syndrome. Now, guys, the first thing about all these syndromes that I would want all of you to know is, which is the most common nephritic syndrome that you have in children or pediatric? And then obviously a similar question would be asked, that which is the one that is seen most commonly in adults. There's a very simple way of learning it. P for P, A for A. Means when you're dealing with pediatric, it is going to be PSGN, post-streptococcal glomerulonephritis. And when you're talking about adults, it is A for A. That is going to be a case of IgA nephropathy. There is IgA nephropathy, and the other name of IgA nephropathy is Berger's disease. So please remember, I hope by now you've anyway remembered it. It's really easy to understand. Pediatrics, P for P, PSGN is going to be the answer. Adult, A for A, IgA nephropathy. But now if I twist the question and ask you, which is the most common nephritic worldwide? So instead of learning it worldwide, I have learned all over the world. All over the world, because that also gives me a mnemonic that all over the world also IgA nephropathy is common. Simple. So IgA tells me that not only is it more common in adults, but it is also more common nephritic all over the world. And that has been a previous year question. Which is the most common nephritic overall all over in the world? IgA nephropathy. So what are we waiting for? Let's start with our discussion. Let's start with PSGN and IgA one by one. So let's begin with the first one, post-streptococcal glomerulonephritis. I've given you a list of sure short questions that are going to come from this topic. And after this topic is saturated, nothing beyond it. So if you've learned these points, you are sorted. Post-streptococcal glomerulonephritis. So obviously, the first question coming to your mind is, what causes it? Streptococcus causes it. Streptococcus causes it. So which streptococcus am I talking about? It is streptococcal pyogenes. And streptococcal pyogenes belongs to which particular family? Asking you microbiology. It is group A, beta hemolytic streptococcus. It is group A, beta hemolytic streptococcus variety. So they ask you what strains. The strains are going to be 12, 4 and 1 in the same order. The strains are going to be 12, 4 and 1. And let me tell you, from this only I can derive the incubation period, because from 12, 4 and 1, if you take the last two numbers, the incubation period is going to be 1 to 4 weeks. So repeating once again, post-streptococcal means streptococcal pyogenes. Strains are going to be 12, 4, 1. Take these two numbers out of it. It's going to be 1 to 4 weeks as the incubation period. I'm missing out on one question. What is it also known as? That I'll tell you in a short while, because I'll explain some microscopic features. You will automatically know the name. But you've understood the strains. You've understood the incubation period. Can I now teach you what are the clinical features? Yes. Going forward, what are the clinical features? So you have to put a little bit of common sense. Streptococcus, don't think of big things like kidney. Think of something very basic. What does streptococcus cause in a general population? Sore throat, pharyngitis. So the first thing that my patient is going to have will always be a sore throat. Now, after a sore throat, many some timeline later, which you guys are going to tell me, some timeline later, there is a patient who now comes to you with cola color urine. Why am I writing cola color urine? Because I know that PSGN is a nephritic syndrome, and anything with a nephritic syndrome means, will there be hematuria? Yes, there is going to be hematuria. But why did I tell you that you will tell me the timeline? Because go back to your immunology chapter, and PSGN is which hypersensitivity? It is hypersensitivity type 3. And I had given you a hint over there and made you practice a question in immunology that any type 3 hypersensitivity reaction takes how many days to manifest? It takes 10 to 14 days to manifest. In simple words, it is 2 weeks. In very simple words, 10 to 14 days. So whenever they give you a history of a pediatric, of a child, PSGN for pediatric, the child had sore throat, and 2 weeks later, the mother is saying that my child is passing blood in the urine, cola color urine, coffee color urine, these kind of brownish colors are used. You are dealing with PSGN. What are you going to do next? You are going to go in for a blood test. Whenever some turn comes to me with sore throat, fever, blood test is what we do. So what am I going to get in a blood test? Think logically. First think logically, because you're thinking in terms of streptococcus. So what do you have to know out here? You will do antibodies for streptococcus. So firstly, I would do some antibody testing. I know the antibody which is coming to your mind for streptococcus that you do is anti-streptolysin O. Yes, you do that for any streptococcus patient, anti-streptolysin O. However, what is better or what is preferred over here is anti-DNase B. Please remember, anti-DNase B is the preferred antibody detection over here. That's the first set of blood tests that you'll do. What is the second test of blood test you'll do? Remember, these patients show you a very, very, very important concept called transient hypocomplementemia. They show you transient hypocomplementemia, which means hypo means less, complement proteins are going to be decreased, especially C3 is decreased. All of them go down, especially C3 is decreased, and this happens very transiently, only for a few weeks. After that, they will automatically come back to normal. Basically, the concept is that till the time the streptococcus antigen antibody are roaming around in the blood, every antigen antibody, I know for a fact streptococcus is an antigen. Yes, it's a bacteria, it's an antigen. I will make antibodies against it. So basically, I am making antigen antibodies complex. I am making an immune complex. Will an immune complex always go and activate my complement? Yes, it will always go and activate the complement. As a result, see, complement is being activated. So obviously, the complement levels will go down. Once the complement levels go down, please remember that the patient is going to show you less of C3. Now, there's one extra edge point that I want to tell you. Although all the complement levels go down, but for reasons unknown, C4 levels tend to remain normal. Again, like I said, the exact reason for this is not known, but C4 levels tend to remain normal. Yes, the most important is that because so much of complement is being activated, the complement levels will go down. Now, once the antigen will go away, after some time the streptococcus will be cleared off. Once the antigen will go away, the immune complexes are going to be removed. Then there is no activation of complement. This means everything will come back to normal. That is why I said it's transient. For some time the complement levels go down, after some time they are back to normal. I hope everyone's okay with it. Yes, so these are the blood tests, and this word is, like I said, very, very, very important. Okay, moving forward, now let's go on to the real pathology part. You already know how it looks grossly. Guys, did I not teach you in the beginning part these pictures? What are these pictures? The very famous flea-bitten kidney. And I gave you a mnemonic also for flea-bitten kidney, and that was We Hate PSM. Remember, in We Hate PSM, I told you that P was for post-streptococcal glomerulonephritis. And you can see these two pictures. You can see the red color dot flea bitten. You can see the red color dot flea bitten. Let me tell you, this is the same picture that came in the previous NEET exam. So remember this, guys. The red color dot is what will make the flea bitten appearance. So that is the gross finding. Now we move on to light microscopy. Light microscopy means regular pink and blue stuff. Thankfully, And I know all of you will be very, very happy knowing this. Thankfully, you don't have to learn any picture for light microscopy, but you have to learn what is happening. And here I can tell you with light microscopy, what is the other name of post-streptococcal glomerulonephritis. So firstly, they said because it's, many people started asking that, is this entire disease only because of streptococcus? I mean, no other bacteria can cause it. No. They said rarely other bacteria like staph and others could also cause it, very rare. So then they said that, when others can also cause it, why have you named it only after streptococcus? They said, let's call it PIGN, means post some kind of infectious. So post-infectious glomerulonephritis was another name given because they thought that other infections can also rarely cause it. Next, when they saw the microscopy, they realized that there is a lot of proliferation of cells that is going to happen. They then called it acute proliferative glomerulonephritis. They called it acute proliferative. Now, what proliferation is happening? So please remember, there's an increase, whatever you know inside a glomerulus, increase all of that. What is the lining of the blood vessels? Endothelial cells. Increase it, guys. There's an increase in the endothelial cells. What are the macrophages of the kidney known as? Come on, think. I taught you in the first part. Macrophages of the kidney, mesangial cells. So there's an increase in the mesangial cells. Then think logically that there is so much of infection, streptococcus or some kind of infection. So inflammatory cells will also come. There's going to be an increase in the neutrophils. There's going to be an increase in the macrophages or mesangial cells. That means overall the kidney is what? Hypocellular or hypercellular? So many cells. The kidney becomes hypercellular. There is a hypercellular glomerulus that is noted, as a result of which, please remember, we call it too much of proliferation. We call it acute proliferative glomerulonephritis. Having said that, you're not going to get a picture, but this description of hypercellularity and too much of proliferation is very, very important. Now, what are you going to get a picture for are these two. What do you see on immunofluorescence and electron microscopy? Guys, you need to understand at the end of the day, it's an antigen-antibody interaction. Antigen-antibody basically means some kind of an immune complex. And when we are dealing with an immune complex, where will that immune complex go and sit? You try to analyze. This is an electron microscopic picture. All of you are very well versed with this orientation that I made you do in the first part. Can you all visualize what are these structures known as? What were these? These were feet, right? Everyone remembers they were epithelial cells. They were the visceral epithelial cells or the foot processes. Now suddenly, do you see one of that foot has become like a mountain? A big mountain. Why has it become like a big mountain? Because there is a deposit that is present over here below the epithelium, below the podocyte or foot process. So I call it subepithelial humps. We call it subepithelial humps. That is what you see on electron microscopy. We see subepithelial humps on electron microscopy. And now the question is that, is the immune complex only going to sit here? No, if you increase the immune complexes, they will sit below in the membrane also, they will sit in the endothelium also, they will sit everywhere. But what is the characteristic? Subepithelial hump. What do you see on immunofluorescence? Please remember, immunofluorescence, that nice shiny green little thing. So you will notice that immunofluorescence is showing you, look at this, some areas. Can you see? Some of the areas are shining very, very bright shining. And then some of the areas are okay, kind of dull. They are not that shiny. Then some areas over here, for example, again, this area is shining. This is shining. This is shining. Why? See, wherever the immune complex will go and sit, that area will shine out. And next it went and sat here, shine. Went and sat here, shine. So shine and dark. Starry sky. That is the very, very famous starry sky appearance. Please remember, starry sky on immunofluorescence for PSGN. Super important, because all of you shall tell me where else do you see, or what are the two starry skies that you have to know in pathology. So one of them is on a routine wala light microscope, the pink and blue. One of them, like I told you over here, is the shiny immunofluorescence. So please remember, the light microscope one is Burkitt's lymphoma. Burkitt's lymphoma shows you a starry sky pattern, and PSGN over here on immunofluorescence shows you the starry sky pattern. These two are questions, and both of them are identified by the starry sky appearance. So remember, already the background is black only for us. So remember these shining stars for yourself. Coming back, what did you see on electron microscopy? Subepithelial humps. What did you see on immunofluorescence? You could see the starry sky appearance. Finally, we come down to the treatment aspect. You know, the best part about this disease is that this seems to be a self-limiting disorder. When I say self-limiting disorder, that is within 6 weeks, it is going to come back to normal. You are not actually needing you don't need major antibiotics, you don't need major treatments. It is actually a self-limiting disorder, and the patient is going to be fine in 6 to 8 weeks. All that you need is supportive treatment. It is only in almost or less than 1% of the cases that this is going to become chronic and it is going to progress. Less than 1% of the cases only. But in 99, I can say 99 and above cases, it is going to go back to normal on its own, and that becomes the end of your PSGN. So let's do a very quick recap. What are the other names? A quick 30-second recap of PSGN. Other names are acute proliferative glomerulonephritis or post-infectious glomerulonephritis. Which cases or strains of streptococcus? 12, 4 and 1. What's the incubation period? 1 to 4 weeks. What are the clinical features? We start from sore throat, go to cola color urine in how many days? 10 to 14 days. Which antibody is the best? Anti-DNase B is the best. What is the most important blood test, which I kept telling you, very, very, very important? It is a transient hypocomplementemia. Transient hypocomplementemia. How does it look like grossly? I told you the kidney is going to show you those dots. That is the flea-bitten kidney. Microscopically, like you said, proliferative, lots and lots of cells. It is hypercellular. Immunofluorescence shows you the very famous starry sky appearance. What does electron microscopy show you? Subepithelial humps. Is there any special treatment that is required? No, it is self-limiting, will be fine within 6 to 8 weeks. That is your under 1 minute summary of PSGN, and I hope you remember P for P, that is, it is most common in the pediatric age group. Yes, seems nice when at the end of a disease you can wrap it up in a single flashcard. That is how you're supposed to study kidney. Okay, having said that, this was all happening in pediatric. We've done the pediatric version. Let's do the adult counterpart of this, and that is IgA nephropathy. So guys, please remember, IgA nephropathy is also known as Berger's disease. And before I start with this story, I want everyone to know there is a difference between these two Bergers in medicine that you got to know. Berger's with a U and Berger's without a U. Please remember, the Berger's with a U is going to be a V, and that is vasculitis. Berger's with a U is going to be with a V, that is vasculitis. This is not the Berger's that I'm talking about over here. Here I'm talking about the Berger's without the U. This Berger's is the kidney disorder known as IgA nephropathy. So first and foremost, like I said, A for it is most common in the adults, and secondly, it is most common all over the world. That is, it is most common worldwide. Now we'll first understand the pathogenesis behind it. So remember, this also is associated with some kind of an infection. That infection could be either a respiratory tract infection, it could be a GI tract infection, or it could be something like the streptococcus only, the streptococcus that you studied right now. So some kind of infection is happening, and you know what problem has happened because of that infection? There is a very different type of IgA that your body starts making. There is an IgA1 form that your body starts making after these infections, which are galactose deficient. Now you'll ask me why? We don't do that all the time. I mean, we get infected with so many things on a daily basis. Do we actually sit down and make this kind of an antibody which is galactose deficient? We don't do that. Why are these patients showing you that? So then they came across, they did a lot of studies for many years, they could not find the reason. Now they are saying there could be an underlying genetic problem. There could be an underlying genetic problem because of which these patients are, because anyone can have a streptococcus or a GI infection, but only these patients were making this weird type of an antibody. That is why they said there must be some underlying genetic problem. Now guys, having said that, please remember that this IgA IgA1, which is galactose deficient, suddenly you realize that this is acting like an antigen. Your body says, I have never seen this. This is not the usual antibodies. This is not like my usual IgA. This is something weird. Can I say this despite being an antibody starts acting like an antigen for me? Because your body has never ever seen such a thing inside it, and suddenly it's seeing something new. It will start attacking it. Can I say there are further antibodies that are produced against this? There are further antibodies that are produced against IgA1, and you know when will this? So you can say this behaves like an antigen and antibodies are going to come across it. This will then go and deposit in the kidney. The antigen antibody complex then goes and deposits in the kidney. Which part of the kidney? So remember, in Berger's, what is the cells which were there in between? Remember, in between, like there's glomerulus. We always say there's a glomerulus, and then we always used to draw that tuft of capillaries. But what were the cells which were in between? Like, for example, if this is a capillary, this is a capillary, this is a capillary, looking like balloons, I'm sorry, but yeah, these are capillaries. What are the cells that you had in between? Did you have the mesangium? That is how you learn it. That BE for between. In Berger's disease, the IgA1 is deposited in between. Basically, there is going to be mesangial deposition. That is what they ask you a lot. There is a mesangial deposition that occurs in Berger's disease. So now I want to ask you in terms of what is the clinical aspect. I've understood. If I had to put a one word or a one sentence summary to it, Berger's disease is also like streptococcus, in which some infection happens, say some sore throat only happened, but the kind of antibody that the person forms is IgA1, which is something foreign for you, and all of that goes and deposits in the mesangium. So how is the patient actually going to present? So remember, this could be again a case of sore throat. And I know that this is a nephritic syndrome. Anything that is a nephritic syndrome will eventually come to me with cola color urine or hematuria. But here there are multiple episodes of hematuria that are happening. And what is the age group? If I'm talking about IgA nephropathy, then the age group is obviously going to be somewhere as an adult. But if I would have written the same story, guys, if I write the same story as a sore throat, and then I say again there is cola color urine, that is hematuria, but this time I change the story into a kid, what would you have told me as the answer? If I would have put the story as a pediatric or a kid, you would have called it PSGN. So you say that in the exam, whenever I get a history of sore throat, and after that I say there is recurrent hematuria or hematuria, will I always think of two conditions? If it's a child, I'll think of PSGN. If it's an adult, I'll think of IgA nephropathy. But what if the age is not given? Then what am I going to do? I will have to look out for the duration. In PSGN, I told you that all of this happens within 10 to 14 days. Whereas in Berger's, it is going to be very, very fast. Very, very fast. That is within 3 days. Some books mention 2 to 3, some books mention 3 to 4. So within 3 days, everything is going to happen. So now by chance, the age is not mentioned. They say there's a person with sore throat and 3 days later, he's got recurrent hematuria. I don't know whether he's a child or an adult. But if they've mentioned 3 days, what are you going to think of? You are going to think of Berger's disease. And the same thing, there's a child with sore throat followed by hematuria. You are going to think of PSGN. So let's do a recap. 2 clinical scenarios. Sore throat in a 6-year-old boy, 10 to 14 days later, cola color urine, young kid, and 10 to 14 days, PSGN. 25-year-old person with having a 3 to 4 day history, you think of Berger's. Everyone's understood. These are like golden clinical dictums that I'm telling you, which are going to help you in solving questions. Now, a lot of students ask me one more question, and that is, IgA is affecting the kidney. I know there is one blood vessel problem where IgA tends to affect the blood vessels. And what is that condition known as? I think everyone is aware. That condition is HSP. So they ask me that what is the difference between IgA vasculitis, IgA blood vessel problem versus IgA nephropathy. And now I think you guys can easily tell me the difference between these two, because when I say IgA nephropathy, tell me the other names. What is IgA nephropathy also known as? It is known as the Berger's disease, right? And what is IgA vasculitis known as? It is known as Hinoch, Schonlein, purpura. You guys remember? We've studied this in immunity. We've also studied this in our vasculitis chapter. Hinoch, Schonlein, purpura. So now you will realize that IgA is there in both, but here IgA is only involving the kidney. Only kidney involvement is there. But IgA vasculitis means blood vessels, and blood vessels are present all over the body. So what is going to be the involvement? What are the organs that are going to be affected? You would know that over here there's kidney, primarily kidney involvement. Whereas in IgA vasculitis, Hinoch, Schonlein, purpura, I always used to give you a mnemonic purpura, that you are going to learn it as purpura, means there are 4 things that you need to know. P will obviously tell me there's something to do with purpuric rash. So there's going to be a purpuric rash very commonly seen on the lower limbs. On the lower limbs, on the thigh, below the buttocks is what is the history given. After that, there is also abdominal involvement. Patient will come to you with abdominal pain. There is joint involvement. Patient will come to you with arthralgia, joint pains. And also there is renal involvement that you have. So kidney, patient will come to you with same nephritic, hematuria. So I can say that IgA vasculitis is a broad term. It includes skin, purpuric rash, means it includes abdomen, it includes joint, and it includes kidney. If I only take out the kidney part, and I say what is that disease known as, that is known as a Buerger's disease. Everyone's understood the difference between HSP and IgA nephropathy? Yes. Coming back, how is this going to look like under the microscope? Like I told you, Buerger's disease was deposition of what? It was deposition of IgA1. It was deposition of IgA1 in which part of the kidney? In between. In between basically means in the mesangium. So this is going to be a very, very important term. Have a look at this. The usual pink and blue. You will realize that the capillaries are all normal. So for example, if this is a capillary loop, this is normal. If this is a capillary loop, this is normal. These are normal. Capillaries don't have a problem. The in-between area, the mesangium, the in-between, see this is a loop. For example, this is a loop and this is a loop. They don't have a problem. Who has a problem? The in-between area over here has a problem. In-between area here has a problem. That is what you see in Buerger's, that all the IgA is getting deposited here. And try to look at the same thing under immunofluorescence. Again, for example, this must be a capillary loop. This doesn't have a problem. This is another loop. This is another loop. This is another loop. So capillaries are normal. The areas in between, look at this. The area in between these capillaries shows you the green color. In between the capillaries is green color. So remember, the mesangium is showing you the deposition. Very, very important. Which means before I move on further, all of you are going to finally make a table for me. What are the things in the mesangium of the kidney that are important? There are just 3 questions and you've done all 3. If you all remember, mesangium had what cells? Mesangial cells are what? Mesangial cells are macrophages. They are macrophages. Number 1. Number 2, if you remember, what is the first place of amyloid deposition? Amyloid deposition first occurs in the mesangium. And number 3, now you know which disease is going to show you deposition in the mesangium. The one in between, that is known as the Buerger's disease. Yes, everyone's confident. These are your final 3 questions and there is no other question that you have to know when it comes to Buerger's. Super, super important. I hope you all will remember this. Okay, having done with Buerger's, I didn't tell you the treatment. The treatment is the same. There's an infection. Treat the infection. What if this becomes again chronic and progressive? So now I've taught you 2 diseases. One is in the kids, one is in the adults. For both of them, I said you treat it, patient will be fine. But what if things progress? Where am I going towards? What if things start progressing? We call it RPGN, rapidly progressive glomerulonephritis. It's sounding like a pathology term or a clinical term. Glomerulonephritis means kidney, okay, but rapidly and progressive. Rapidly means patient is deteriorating, his kidney function is deteriorating rapidly. So rapidly progressive glomerulonephritis is going to be a clinical term. And I am currently trying to integrate the clinical aspect with pathology. So what do pathologists call it? Rapidly progressive glomerulonephritis is known as crescentic glomerulonephritis. Crescentic glomerulonephritis. You'll obviously want to know the meaning of a crescent. Never mind. Have a look at this picture. Can you see this round glomerulus over here and this round glomerulus over here? But someone is sitting on top. Have a look at this, guys. For example, this fist of mine is a glomerulus and you have something like a flap on top of it. So this is a glomerulus and there's a flap. So flap, crescent is nothing but this half. Can you see what shape have I made? A half moon kind of a shape. So that half moon shape is present on the top. That is what you call as a crescent. So that is what I've done. I have now nicely made a half moon kind of a shape over here. I'll draw it once again. You have to notice this very carefully. On top of the glomerulus, there's something like a cap that is sitting. So please remember this half moon shaped structure is what you call as a crescent, and they ask you what is the composition of a crescent. You know, why was I? Firstly, everyone's understood the shape, right? It's something which is going to look like a half moon. A lot of people call it different names. Some people say it looks something like a sickle. Some people call it a half moon. It's apna imagination, whatever you want to call it. So someday when you guys are done with your exams and you become big doctors and you start doing advanced studies, maybe you will give it a new name and it will come in the books, right? So it's got a lot of names: half moon, sickle, crescent. The question that comes is that what is the composition? Remember, what was I calling it? I said this is a glomerulus, this is a flap. I was calling it a flap. There's a reason why I was calling it a flap. Not that I want my name to be written in any book. I was calling it a flap because this is composed of flap. That's your mnemonic. So what is a crescent composed of? F for it's made up of fibrin. It's made up of fibrin. L for it is going to have leukocytes. It's going to have leukocytes. A for and. P for parietal epithelial, more commonly than visceral epithelial cells. Parietal epithelial and visceral epithelial cells. But I kept only parietal epithelium in my mnemonic. I have not kept visceral. I've labeled it as flap because I want everyone to primarily learn parietal epithelium, because more commonly it is parietal only. So now the question comes that your crescent of flap is made up of fibrin, leukocyte, parietal epithelial cells, visceral epithelial cells, and all of the above. You select all of the above. But if I say options are fibrin, leukocytes, parietal and visceral, and I say which of them is least likely to be found in a crescent, least likely is obviously going to be the visceral epithelial. The visceral will be the least likely. So that is how questions will come. So you learn your basic mnemonic flap. These are the main things. But now the update says that visceral epithelial cells can also be present. Well, having said that, this is all pathology. You say you are seeing one crescent. I say no, I am seeing 5 crescents. Is that going to make any difference for the patient? Yes. Please remember that increase in the number of crescents means that the patient is going to have a pathetic prognosis. It is very, very bad for the patient. It is going to be a poor prognostic category. So if you say you're seeing 1 crescent, I'm very happy. But if I get to see 5 crescents, means it's very, very bad. Means the patient is in a progressing state. The patient is deteriorating. More the number, worse the prognosis. Having said that, RPGN, as I said, is a clinical term, and this clinical term is divided into 3 further clinical groups: RPGN type 1, type 2, and type 3. So please remember, all of that you studied up till now. Remember, we did something called post-streptococcal in children, Berger's in adults, and I kept telling you that they might become aggressive, they might become progressive. They are all RPGN type 2, okay? So let me start off. What all do we have? RPGN type 1. RPGN type 1 is known as GPS, Goodpasture syndrome. Right? And Goodpasture syndrome is actually what? It is antibodies against the basement membrane. Anti-glomerular basement membrane antibody syndrome is going to be Goodpasture syndrome. So Goodpasture syndrome RPGN1 is a problem in the glomerular basement membrane. I'll tell you all these diseases in detail. But remember, every RPGN1 is going to show you a linear immunofluorescence. Linear means what? Have a look at this picture. If you pick up this glomerulus and you pick up this glomerulus, you all would agree that there is no light and dark, light and dark. It is not like the starry sky pattern. No, guys, this is all the same. This is the same green color. As if I took a green color pen, it's looking like this. I took a green color pen and with the same pen, I have drawn the line all over. See, there's no dark, there's no light. It's the same green color everywhere. This is what you call as linear. You can have a look at here also. The same green color going everywhere. This is known as linear pattern. So please remember, RPGN type 1, the way you write 1 is the way you write linear. So RPGN type 1 shows you the linear pattern. Now let's come to RPGN type 2. Type 2 has two things. What do I say two things? Means whenever I can see some antigen and antibody kind of a thing happening. Like in PSGN I could see antibody, antigen, antibody things. In Berger's I could see infection, antigen, antibody. HSP and SLE are all related to antibodies only. So all these antigen, antibody things come under type 2. And do you remember what was the immunofluorescence in PSGN? Starry sky. So the same immunofluorescence is coming over here. They've given it more names. They sometimes call it lumpy bumpy. They sometimes call it granular. So now I want to tell you that all these appearances are given multiple names. So have a look at this. Are we back to the fact that this area is shining more over here, then this area is shining a little more, this area is shining more, this area is shining more. So some areas are shining and some areas are not so shining. So these can either be known as granular, or they can be referred to as lumpy bumpy, or they can be referred to as starry sky. They are the same things. These are, and one more name I'll tell you. Some people also call it a garland pattern. This is also known as a garland pattern. So all of these are the same thing. Granular, lumpy bumpy, garland, starry sky, all of them are the same thing. Yes, they are seen in PSGN also, and they are going to be seen in RPGN type 2 as well. Similarly, I'll tell you one more thing. Do you guys know for RPGN type 1, how they can give you a twisted question? What have you learned? What pattern is it going to show you? Linear pattern. They don't want to write that word linear. They want to write it ribbon. Apna imagination, like I said, they want to write it like a ribbon. This is looking somewhat like a direct ribbon. So instead of writing linear, they can definitely write the word ribbon for you in the type 1 RPGN also. Having said that, coming to the last one, that is type 3 RPGN. This is also known as, I have studied these diseases earlier, microscopic polyangiitis and Wegener's granulomatosis. These have been studied where? These have been studied way back in your pauci-immune vasculitis. What did I say? Pauci-immune vasculitis. Pauci-immune vasculitis is what you read it in. So pauci, the word is only telling you, is it going to have any immunofluorescence, any kind of immune deposition? No, pauci means less. There is no immune deposition. And do you guys know, this RPGN happens to be the most common RPGN that we have. So there is a question like this also, that RPGN type 3 is the most common. We've done the basics. I realize RPGN type 2 variety, PSGN, IgA, HSP I've studied. RPGN type 3, that is microscopic M and W, we have already studied in vasculitis. The only disease that I have not studied over here is Goodpasture syndrome. So I'm going to go ahead with that now. And Goodpasture syndrome is very, very famously known as the 1, 2, 3, 4 disorder. So it's personally my favorite kind of a disorder. So that is what I'll start with. Please note, what did I say? 1, 2, 3, 4. Okay. Let's see if you guys have read this in medicine, because you should be able to answer it. So Goodpasture, which kind of RPGN did I call it? Which kind of RPGN? It is type 1 RPGN. It is type 1 RPGN. Go back to your immunity chapter. Which hypersensitivity reaction is it? It is a type 2 hypersensitivity reaction. Come back to this chapter. What did I give you as the other name of Goodpasture syndrome? It is anti-glomerular basement membrane antibody disease. Anti-glomerular basement membrane. Guys, basement membrane is which collagen? So many times I've told you. Basement membrane is type 4 collagen. Basically, you have antibodies against type 4 collagen. There are going to be antibodies against, do you know what? Alpha 3 chain of type 4 collagen. That is your 1, 2, 3, 4. Let's repeat. Which RPGN am I talking about? It is type 1 RPGN. Which hypersensitivity? Type 2 hypersensitivity. Which alpha chain? Alpha 3 chain of type 4 collagen is going to be affected. I hope everyone's understood the 1, 2, 3, 4 of Goodpasture syndrome. But a question must definitely be coming to your mind is that collagen or basement membrane is just not present in the kidney, right? It's present in other organs also. So you can't say only kidneys will get affected. One more organ gets affected over here, and that is the lungs. So Goodpasture syndrome is involvement of two organs, means when the lungs are affected, patient is going to complain of bleeding in the sputum, hemoptysis. When the kidney is affected, patient will complain of bleeding in the urine, that is hematuria. Repeating, there is bleeding in the sputum and there is bleeding in the urine that is going to occur. But if they ask you what is the most common cause of death, which failure is going to most commonly cause death, it is the giving up of the kidneys. Giving up of kidneys basically means uremia. The most common cause of death in Goodpasture syndrome will be uremia. Now tell me one more thing. It is a type 1 RPGN. What is going to be the immunofluorescence? Like I told you, the way you write 1, I hope you all remember, the way you write 1 is the way you write linear, means there is going to be a linear immunofluorescence. Everyone remembers? You can have a look at that picture once again. This is linear immunofluorescence, which you see in RPGN type 1, basically what you see in Goodpasture syndrome. Having said that, guys, coming all the way back, this means I have studied all of these. I have studied 1, 2 and 3 in detail. But in this disease, I did not show you any electron microscopy. So now I'm going to show you a common electron microscopy which will make sense, and I'll give you a nice movie mnemonic out of it, and that is RRR. Everyone's favorite movie now, the biggest movie that we've ever had. RRR tells me that when you are dealing with RPGN, can you look at this picture? Firstly, it's a black and white picture. That is obvious. Secondly, what I realize is that there is something over here which is up till here and then it's broken. I can see a break over here. Then the second part is broken here and it's entangled over here. So basically something has ruptured. Something has ruptured. So actually it's a basement membrane. There is a rupture of the basement membrane. But tell me one thing, has it only broken or has it wrinkled also? This side has wrinkled, this side has also wrinkled. So it was like this. Not only has it broken, it has also wrinkled. See, not only has it broken, but it has also become wavy. It's wrinkled. So there is rupture and wrinkling of the basement membrane that you see in RPGN. Repeating, in RPGN there is going to be a rupture and there's going to be a wrinkling of the basement membrane. All of you can visualize this, yes? And that is going to be common to all these three. RRR is seen in all. With which we finish off RPGN, but there's one thing that is still bothering me. When I was teaching you Goodpasture syndrome, I only told you that there is alpha 3 chain involvement. So many students come back to me and ask me, what if there is alpha 4 involvement, alpha 5 involvement? What are those diseases known as? So please remember, now coming to the next. Thin basement membrane disease. Just keep listening to me. In the end, you know, I'm never going to let you go without a mnemonic, because I know all these things get confusing and messed up in the exam later on. All the, neurons will start cross-firing in the exam. I don't want that to happen. So listen to me, understand the concept, and don't worry about the mnemonic. So what is thin basement membrane disease? Firstly, I can see the name itself. The basement membrane is going to become very thin. So you would ask me, how thin? Remember, it is less than 200 nanometers when I say that the basement membrane is thin. And why has that happened? Because there is a defect in alpha 4 chain of type 4 collagen. See, basement membrane collagen is going to remain the same. Basement membrane collagen is going to remain the same. It is only the chain that is going to change all the time. So can you all recall for me, what was the chain that you had in Goodpasture syndrome? The chain in GPS was the alpha 3 chain. It was the alpha 3 chain. Now in thin basement membrane disease, it's alpha 4 chain. That is why the basement membrane has become super thin, less than 200 nanometers. You know what is this also known as? BFH. Benign familial hematuria. This is also referred to as benign familial hematuria, which basically means patient is going to have blood in the urine. That is why I'm studying it under nephritic syndromes. This is going to be running in the families because I can see there is a genetic problem happening. But why did I add the word benign? You know, we all have that way of thinking that many people in the family are having hematuria. Many people in the family are having hematuria. Immediately you start thinking, do they have cancers? Do they have cancers of the bladder in the family that are running? So they want to tell you, no, this condition has nothing to do with cancers. It is not a cancerous condition. It is a benign condition. So they call it BFH, benign familial hematuria. That is thin basement membrane disease. So see, alpha 3 chain done for good pasture, alpha 4 chain done for thin basement membrane. Now we move on to the last disease where there is a problem in the alpha 5 chain of type 4 collagen, and that disease is known as Alport syndrome. Repeating, alpha 5 chain. So guys, when you write Alport, it's going to be very interesting. When you write Alport, all your mnemonics come across with Alport. So remember, Al for alpha and port for penta. Alport. So which chain? Alpha 5 chain is going to have a problem. Also go back to your genetics. If you remember, it has what inheritance? It has all the inheritances, means it can be autosomal dominant, autosomal recessive, it can be X-linked recessive, it can be X-linked dominant. So all of the inheritances are possible. However, if you have to select one, do you remind yourself of the genetics chapter? If you have to select one, you are going to call it XLD. The most common inheritance is XLD. Okay, so two things. Alport tells me all of the inheritances are possible. Second, Alport tells me alpha and P tells me penta. So the alpha 5 chain is going to be affected. The classical triad is what they are going to ask you next. Obviously, there is involvement of kidney because you are studying the kidney chapter and you have studied that it has the nephritic syndrome. So kidney is the most common, of course. Apart from that, there is going to be a problem in the eyes and there's going to be a problem in the ears. Please remember, in the eyes, there is an anterior lenticonus, and in the ears, there is sensory neural hearing loss. So what did I tell you? 3 organs are affected in Alport. There is a kidney, there is eyes, and there is ears. But which is the most common? You're studying it in kidney chapter, so kidney is the most common. However, which is the most common extra-renal? Other than kidney, what is the most common manifestation? So the most common extra-renal manifestation is going to be sensory neural hearing loss. Having said that, guys, now all of this is okay, but how do you do the diagnosis in kidney? And the good news is that I don't have to teach you any light microscopy, any immunofluorescence, because for Alport syndrome, the gold standard for Alport syndrome, if you are asked what is the gold standard, it is going to be electron microscopy. And you can see that black and white picture in front of you, and you will have to divide this black and white picture actually into 2 parts. So what is it? The first part is to show you the normal once again. Can you see that? Look at this, guys. Whenever I say show you a black and white photo, try to look for the feet. Always try to look for the feet. That will give you orientation. I can see the feet over here. Yes. Okay, the feet look fine. Now I've got that entire aspect here. After I look at the feet, I have to look at the thing under it. What is that layer under the feet? Is it the basement membrane? Is it looking totally fine? Have a look at it. The basement membrane, I'll draw it again. It's looking totally fine. This is for comparison, because now when you come to the picture below, you can all visualize over here what is happening. Now, again, when I see the feet, everything is fine, but the basement membrane below the feet is looking very different, as if I have tried and pulled 2 pieces apart. I have tried and pulled 2 pieces apart. That is what has happened to the basement membrane. That is what you call as a basket weave. You must have seen this pattern, how weaving is done, how chairs and jute chairs and baskets are made, right? So that weaving, that square hole pattern. Actually, I can see the same. I can see multiple holes. I can see multiple holes that are present over here, है ना? And please remember now, guys, that this is going to happen in, which layer of the basement membrane? This happens in the lamina densa. So remember, there is a basket weave pattern of the basement membrane, and that happens in the lamina densa part of it. So repeating, when I'm talking about Alport, it has all the inheritances. It has Alp, that is alpha penta, alpha 5 defect. It has a triad of kidney, eyes and ears. Kidney is the most common organ affected, and that shows you the basket weave appearance. This means I have to give you this kind of a mnemonic, otherwise you're going to forget all the chains. So the concept was that the basement membrane is affected. What? The glomerular basement membrane is affected. Means which collagen? If I'm saying glomerular basement membrane, we are talking about type 4 collagen. We'll write it over here only. We are talking about type 4 collagen. Which chain do we have? 3 chains ka option I had for all of you. There was something called alpha 3 chain, alpha 4 chain, alpha 5 chain. So if you write alpha 3, 4 and 5 and you write glomerular basement membrane, you are sorted. Because if alpha 3 chain has a problem, the disease was Goodpasture syndrome. If alpha 4 chain had a problem, you had benign familial hematuria, which was nothing but basement membrane being thin. So either you learn basement membrane thin or you learn benign familial hematuria, it's a B. And when alpha 5 is problematic, I have made it into a W. Means weaving, basket weave appearance, and you already know alpha penta means we are talking about Alport syndrome. So please remember guys, alpha 3, 4, 5 you write in the exam, glomerular basement membrane you write in the exam. Alpha 3 matlab GPS, alpha 4 is basement membrane thin, and alpha 5 is anyway alpenta, in which you see the weave appearance, and this is your final mnemonic. So I told you that first you have to understand, and I will always help you with the mnemonic thereafter. With which we wrap up all our nephritic syndromes, means we are definitely ready for some questions. Coming to this one. Regarding the pathogenesis of crescentric glomerulonephritis, which of the following is the first and the most crucial event that leads to a crescent formation? Now guys, you already know what was a crescent. This is an indirect question, so you have to be very, very cautious while answering it. What was a crescent made up of? Crescent was made up of flap, if you remember. Means it had parietal epithelial cells. So it can't be associated with, the parietal is outermost. Something has to start from inside. Leukocytes, there is no option of leukocytes. It was made up of fibrin also. Where is fibrin coming from? Fibrin will always come from blood vessels. Fibrin, fibrinogen, it will always come from blood vessels. So what is going to be the first and the most crucial event in the formation of a crescent? It is an endothelial injury. That is where how the fibrin deposition, that is where from all the fibrin deposition is going to begin, and that is how the crescent formation shall start, right? So this was an indirect way of asking you this question. Coming on to the next one. Here you go. There's an 8-year-old boy who presents with sore throat, 8-year-old boy. No medication was taken for the same, and the child seemed apparently well until 2 weeks later when he developed cola color urine. The mother rushed to the doctor to get a urine examination, and that revealed a field full of RBCs and mild proteinuria. So based on the clinical history, which hypersensitivity reaction is seen? So firstly guys, I see there is a kid. I have some pediatric disorder mentioned. Then I have a history of a sore throat, and how many weeks later, or how much time later? 14 days later, there is cola color urine that the mother has told you about. Also, field full of RBCs tell me cola color urine, hematuria and mild proteinuria. I am also certain that we are in the nephritic range only. This is a classical case of post-streptococcal glomerulonephritis, and I told you that it falls under type 3. So this is a real integrated question where they've taken up a little bit of medicine, a little bit of path, and integrated it way back to hypersensitivity reactions. Moving on to the next question. There's a 29-year-old male who presents with hematuria and mild proteinuria. As soon as they say hematuria and mild proteinuria, what is the disease? You start talking about nephritic syndromes. the serum creatinine levels are raised, histopathology is shown. What do you see in histopathology? Do you all see that crescent? I hope you started thinking of the crescent or the RPGN. You started thinking of rapidly progressive glomerulonephritis. Yes. Which of the following causes is least likely? This is what students don't read. Least likely, guys. RPGN type 1 was what? RPGN type 1 was good pasture syndrome. This is there. RPGN type 2 had PSGN, IgA, all that is not mentioned. RPGN type 3 had these two, microscopic polyangiitis, M and W, microscopic, and Wegener's. What is least likely? Polyarthritis nodosa was nowhere mentioned. Go back to your vasculitis chapter, you will realize polyarthritis nodosa does not cause glomerulonephritis. That is what we had studied. It does not cause glomerulonephritis. Moving on to the next question over here. Let's say this is a typical medicine and path correlation. A 55-year-old male patient is over here who's presented with hematuria, mild proteinuria. Which syndrome? Nephrotic or nephritic? We are in mild, so this is nephritic. Along with that, so kidney involvement is mentioned over here. Along with that, there is hemoptysis. So this means there is lung involvement also. Which disease starts coming to your mind in kidney and lung? Good pasture starts coming to my mind. Still, I see serum creatinine levels are raised. Electron microscopy is shown. What is electron microscopy showing you? That RRR, rupture and wrinkling of the basement membrane seen in RPGN. Which RPGN? If I'm thinking of good pasture, which RPGN? We are thinking of RPGN type 1, good pasture syndrome. What is the next line of action? What do you do in good pasture syndrome, guys? Which antibody are you expecting? Anti-glomerular basement membrane antibody. So what is the thing that you're going to do next? You will check for anti-GBM. Will you do anti-nuclear antibody levels? No, this is not SLE. Are you going for streptococcus over here? Not at all. You can't just sit, wait and watch. Patient is having symptoms, hematuria, proteinuria, hemoptysis. So the next testing that you do is glomerular basement membrane antibody. Let's move on to the next question. I've got you more questions because I want you to be familiar with all patterns of questions here. A 55-year-old male patient, again the same thing. Hematuria and mild proteinuria means you are in nephritic range. With hemoptysis means there are two organs affected. Hematuria, mild proteinuria tells you kidney nephritic syndrome, and the lungs are also affected. Are we still again somewhere in GPS? Good pasture syndrome means RPGN type 1. Think of 1, 2, 3, 4 mnemonic immediately. Think of 1, 2, 3, 4 mnemonic. You have an immunofluorescence also shown. Which pattern is this looking like? This is looking like the linear pattern. So guys, is this type 1 RPGN good pasture syndrome? Yes. So will it show you the linear pattern? Yes. Is it type 2 hypersensitivity reaction? Correct. Is it alpha 3 chain of type 4 collagen that is affected? Correct. Are all RPGNs famous for showing you a crescent? Correct. Is this showing you lumpy bumpy deposits? Of course not. I told you the first thing, the picture is telling me. This is not showing me lumpy bumpy. This is showing me linear deposits. Coming to the next and the last question. Mark the correct combination for a thin basement membrane disease. I realize basement membrane type 4 collagen is written everywhere. Type 4 is written everywhere. Now you need to know which chain I want to select. So we used to write glomerular basement membrane and then write alpha 3, alpha 4, alpha 5. Where do you have basement membrane thinning? Where is that coming? So it is the alpha 4 chain. So what are you going to mark? Option number 4 is the answer out here. Having discussed the nephritic syndromes, let's begin with the next part, and that is the nephrotics. Before we begin, I think it's important that we sit down and discuss the common points once again. For nephrotic, if you remember, there was massive proteinuria. What was the definition of massive proteinuria, guys? More than 3.5 grams of protein in a 24-hour urine sample. Apart from that, we had lipid coming out into the urine, and because of so much of protein and so much of lipid coming out, we said that the urine started getting a frothy appearance. Moving forward, we also had that when all the protein was going out into the urine, the levels of proteins were becoming less in the blood, leading to edema. However, what was the most common cause of edema? It was sodium water retention, right? And finally, because antithrombin 3 is also lost, the anticoagulants are lost, as a result of which the patient can have thrombolic phenomena also. So yes, having said that, there's one extra edge thing that I want to add on over here. I assume that many of you might not have read about this. So I'm giving you a brief because a lot of details about this concept I will be telling you once we go to the hematology part. But there is something known as SPEP, means serum protein electrophoresis, which you study in biochemistry also. Serum protein electrophoresis. So please remember, you are looking at, there's a technique called electrophoresis, and you're looking at the blood proteins. You're looking at the serum protein. So this is how the normal proteins in your blood look like. The normal tracing, guys, that we have is going to look like this. The maximum that we have in the blood is going to be albumin. After that, we have minor proteins called alpha-1 protein, alpha-2 protein, the beta protein, and the gamma. Gamma is what? The immunoglobulins. So many people learn it like this also. The hand is also how it is commonly used over here. So what do I mean by in the hand? This peak, this tiny little finger peak that we have, this is the albumin. Then you have three fingers, right? So alpha-1, alpha-2, beta, and then you have this kind of a small little hill kind of a thing. That hill kind of a thing is going to be the gamma. So let's do a repeat. This tall little peak, the tall peak that you have, that is going to be albumin. Then you have three fingers, they are going to be alpha-1, alpha-2 and beta. And then you have this small hill, and that is going to be gamma. So many people learn SPEP as their hand. But now, do you notice what has happened in a case of nephrotic syndrome? You guys tell me on your own, what had happened to the level of albumin? When all the albumin has gone out into the urine, in the blood, what is the albumin level going to be? Can you see there is a dip that has happened? Can we all see that the albumin levels have gone down? Now think logically, if one protein is going down in your body, don't you feel your body will try to make something and try to compensate? Your body tries to fight till the end. So your body then tries to increase the levels of alpha-2 in the system. This is a compensatory increase. So remember, if they ask you what are the SPEP findings of nephrotic syndrome, the SPEP findings of nephrotic syndrome, please note, number one, there's a decrease in the albumin, and number two, there is an increase in the alpha-2 proteins. You will see this in a lot of your grand tests and in a lot of your GT questions, MCQs, subject-wise tests, all-time favorite. And now that I've taught you this much, what do you think will happen in a case of multiple myeloma? What do you think will increase in a case of plasma cell cancers when a lot of antibodies are being formed? Of course, there's a peak that will come in the gamma region that will happen, right? So the same thing I'll teach you once we go to multiple myeloma, but the concept is the same. If you know this hand of yours, you are sorted. Having said that, coming back, we are talking about the nephrotic syndrome. So first, as always, it's important that we do the age group wise analysis. Please remember the nephrotic syndrome, which they ask you, which is the most common that you see in children. Next, obviously, there'll be which is the most common that you see in adults. And over here, there's also which is the most common that you see in elderly population. So remember, in children, the most common is going to be minimal change disease. It is MCD, that is minimal change disease. So how I have learnt it is, minimal is the name of the disease, minimal will be the age of my child. So minimal age child, minimal age is the minimal change. I'll come back to the others. In adults, it is focal segmental glomerulosclerosis, and in elderly, it is membranous glomerulonephropathy. Also, guys, elders are the ones who usually have cancers. So which is the most common renal problem that happens in patients with cancers? That is also going to be membranous glomerulonephropathy. So these are the three things that we have to study now. Let's get going into their details. What is it in children? Minimal age, minimal change. So the first disease and the questions that you have to answer in minimal change disease. What is the age? I think that's not going to be a problem. This occurs in very small kids, usually of the age group of 2 to 6 years, and therefore it is called as the most common nephrotic syndrome that we have in children. Or pediatric. Next, what is the cause? There's a big question mark in terms of the cause. They say it's probably not known. It is very poorly understood, but there are a lot of hypotheses. They have found that this is associated with people having allergies like atopy. They have found this is associated in people having or kids having Hodgkin's lymphoma. So they found a lot of associations, but they couldn't come down to that one final answer that this is the reason that why nephrotic syndrome is happening. But the best mediator that they could come down to was that there is an increase of something known as lymphokines that was seen in all these patients. Whether it was a minimal change disease associated with atopy, allergies, or whether it was associated with Hodgkin's, remember, an increase in the lymphokines is something that was noted, and that is a previous year question. Lymphokines are elevated in minimal change disease. Now let's come to the clinical features. In the clinical features, I suppose everyone would be knowing by now that this is a nephrotic syndrome. Nephrotic syndrome means all the protein, massive, oh my god kind of protein is going out into the urine. But do you know these patients suffer from something known as selective proteinuria? They suffer from selective proteinuria, means selectively which protein is going out into the urine? Selectively albumin is going out into the urine. But whatever protein may be going out into the urine, the patient will ultimately have episodes of edema, episodes of swelling and episodes of edema. But remember, selectively albumin is going out. And do you know, it's not something only from pathology point of view that I'm telling you. It has a clinical implication, because anyone who has selective proteinuria and only albumin is going out in the urine, and you tend to treat that patient with steroids, that patient shows an excellent 100% response. There is an excellent response noted whenever there is selective proteinuria and you use steroids. Now let's come down to the real pathology part. What are the pathology findings going to be? The good news is that the reason that I called it minimal change disease basically means that everything is going to be minimalistic. So remember, the gross finding, nothing. There is a normal kidney that you see, and this is going to be quite an important hint. Nothing. The kidney looks like a normal kidney. Okay, then you say, let me do the light microscopy. On a light microscopy, again, why did I call it minimal change? Because hardly I'm going to see any change. The glomerulus is going to look totally normal. There is going to be a normal glomerulus. Then if everything is normal, I should have called it no change disease. I should have just labeled it as no change disease. Why am I calling it minimal change? Something minimal, minute must have happened. And do you know, in these patients, they tend to show you lipid deposition in the proximal convoluted tubule. See, glomerulus, it's ideally a glomerular problem, and glomerulus is showing you nothing. A tiny little change is seen in the PCT, that is lipid, and that is why I call it minimal change disease. And because of this, we also call it lipoid nephrosis. I hope you've understood why in some books minimal change disease is written as lipoid nephrosis, because there is little bit of lipid in the proximal convoluted tubule. Coming to the next, immunofluorescence, nothing. Again, there is no antigen-antibody complex forming over here. There is no deposition. Immunofluorescence shows you no fluorescent color. You know, the reason for this is they call it nil deposit disease. You're seeing so many names now. All these names are now making sense. Number one name of minimal change disease is lipoid nephrosis, because it is showing you lipid in the PCT. Number two change is known as NDD, nil deposit disease, because it does not show you any deposition on immunofluorescence. So think logically. When nothing is seen on gross, nothing is seen on light microscopy, nothing is seen on immunofluorescence, how do I make the diagnosis of the patient? So then comes the gold standard. The gold standard, the superhero to save everyone, and that is electron microscopy. So as they say, electron microscopy is the gold standard for minimal change disease. And what do you see? You will have to divide this picture into two parts in order to understand. And I have always told you, you see an electron microscopic picture, you look out for what? Find the feet. That's the rule. Find the feet. So can you see the feet over here? Yes. The feet seem to be fine over here, but suddenly the feet do not seem to be fine over here. And this flattening out that is happening, this fusion and flattening out of the feet that is happening, is known as effacement of the foot processes. This is referred to as effacement of foot processes. So please remember, guys, these feet tend to almost look flattened out. Effacement of foot processes is noted, and that is minimal change disease. The treatment aspect I've already told you. You give steroids, you get an excellent response. That wraps up everything about minimal change disease for us. Means we are free to now enter into the world of adults. That is focal segmental glomerulosclerosis. Let's get going. This picture is the definition. So you have to first analyze this picture very well. What is this? Focal segmental glomerulosclerosis. These 4 words. That is why we call it FSGS. And like I said, this is the most common nephrotic that you see in adults. So let me understand the meaning of the word focal and segmental. Glomerulo word has told me that glomeruli will be affected. It's common sense. There is going to be glomeruli. Whenever we use the word sclerosis, sclerosis always means it's in pathology, everything is pink or blue, right? So sclerosis is going to be pink color material, but in actual meaning, sclerosis means something is becoming stiff. So I will be seeing some pinkish color material out here, which is going to be there, and I can. For example, if this is a glomerulus, can we all appreciate there is something which is a little pinkish here and there is something a little pinkish here? So yeah, that much analysis I can do. There is some pink material, but that pink material is going to be focal and segmental. That meaning I have to understand. So what is the meaning of focal? Focal means few glomeruli. Focal means few glomeruli are going to be affected. So for example, if I draw this as your kidney biopsy, okay, this is your kidney biopsy, and I have drawn 5 glomeruli. Just as a random example, these are 5 glomeruli. So now tell me, in how many of them have I drawn the pink material? In how many of them? In 3 out of 5, I have drawn the pink material. In few of them, 3 out of 5. So that means this disease is focal. This disease is focal. Also, did you notice, did I put the entire glomerulus as pink? No. A part of the glomerulus I had put as pink, not the others. So means, what is the meaning of the word segmental? Segmental basically means a part of the glomerulus. Segmental basically means a part of the glomerulus. So repeating once again, when only few glomeruli are affected, like 3 out of 5 or 2 out of 5. So few is focal. Few word means focal. When only a segment or a part is affected, that is going to be segmental. So has everyone understood the meaning of focal segmental glomerulosclerosis? Because although the disease you have understood, but for your terminology, you should know what are the opposite. What is the opposite of focal? Focal was few, only 3, 2 glomeruli affected. Diffuse is all the glomeruli affected. So the opposite of focal is going to be diffuse. Second, when only a segment was affected, you called it segmental. But when, just imagine, just giving you as an imagination, if the entire glomerulus like this has become pink, what would you call it? Then you would call it the global. It's become like a globe, like the round globe. So then you would refer to it as global. These are some opposites that I want to tell you, because later on in other diseases, I will be telling you there is diffuse sclerosis, global sclerosis. Then you won't understand the terminology. So right now, focal means few, segmental means a part. So tell me, for example, if this is a glomerulus and this is a glomerulus, is the entire glomerulus coming out pink? No. I can see that, okay, there is a division. I can see only this much of the glomerulus has come out to be pink. Only this much of the glomerulus has come out to be pink. Otherwise, it's not. So little segments are there. That is what we call as FSGS. Okay, so definition is done. Now you come to the causes. FSGS is of 2 main types, which is primary and secondary. Primary is my favorite type because the reason for it is idiopathic. Idiopathic means we don't know the reason, you don't have anything to learn. The secondary one, of course, is HRs. What is HRs? 3H, 2R, 1S. These are what you have to learn. So what is 3H? Remember, if you have a case of HIV positive, very common FSGS. If you have a case of hypertension in the kidney, it will show you FSGS. If you have a case of heroin drug abuse, if you have a case of heroin drug abuse, then also it is going to be FSGS. So repeating once again, HIV, hypertension, heroin drug abuse, all of them show what in the kidney? FSGS. The 3H is done. Now we move on to the 2Rs. Whenever there is a case of reflux in the kidney, in simple words, there is reflux nephropathy. if there is reflux nephropathy, and also if there is any renal tissue loss for whatever reason, maybe because of a cancer person had to undergo a surgery and renal tissue was lost, or someone is born only with one kidney not being there. So any kind of renal tissue loss, whatever is going to be left is going to be resulting in FSGS. Finally, we come to the S, and what is the S? It is a case of sickle cell anemia. So remember guys, when we are talking about 3H, 2R and 1S, all these things cause FSGS. They are not just a mnemonic, these are all clinical scenarios in front of you. So the question starts off as HIV positive patient, a hypertensive patient, or a patient on heroin drug abuse, or someone with a reflux. These are all going to be types of FSGS. Now a question came in the exam, HIVAN is what? And everyone came back and told me we've not studied HIVAN, some new disease came. No, you guys have studied HIVAN. What is HIVAN? HIVAN is HIV associated nephropathy. HIVAN is HIV associated nephropathy. So HIV associated nephropathy. So sometimes in the paper it's more about common sense and keeping your mind alert and open in a calm manner rather than knowing too many things. If you attempt the paper well with all your senses working well, you can actually get a good rank even with a very concise knowledge that you have. Okay, having said that, next we need to know certain types of FSGS, and you know by now, I don't have to emphasize, you all know that there is a very famous classification, Columbian, and you know the examiner loves these famous words, right? These fancy words. So what is Columbian classification? Actually, Columbian classification says that FSGS is of 5 types. I am interested in 3. There is something called FSGS NOS. NOS means not otherwise specified. NOS means not otherwise specified. Then we have something known as FSGS, a very small part of the kidney is affected. Glomerular tip type, a very small part is affected. Then there is FSGS, entire glomerulus. See, everything has collapsed. Collapsing type is going to be the third one. These 3 are more important. Means, which is the most common? NOS, the one which is no special type. No special type is the most common. Which of these is sounding good? When I said a little bit of the glomerulus is affected, that is sounding like a good thing. So this means that is the one that is going to carry the best prognosis. That is the one with the best prognosis. Whereas when I say everything has collapsed, the glomerulus has collapsed, that is sounding very bad. So that is of course going to have the worst prognosis that I see over here. So now I'll ask you an indirect question. What if you are dealing with a case of HIVAN? Which type do you think are you going to mark out of these? HIVAN or HIV is going to result in what? HIV is a very bad disease, bad prognosis disease. So the kind of FSGS you would link it with is the bad one. So remember, HIVAN is associated with FSGS collapsing type. Okay, like I told you, Columbian classification says there are 5 types. So there are 2 tiny little ones which I'm going to write over here. You want to learn them, don't want to learn them, your wish. There is also something known as a perihilar type. And then there is something called as a cellular type. There's a cellular type. So these are 2 additional things that you have to know. If you can work it around it, you learn it, very good. But the first 3, the main ones, are the most important. Well, having said that, we have done 2 things. We've done the childhood one, we have done the adult one. Now I want to take you into a very primitive, means a childhood se bhi chota, that is a congenital form. What do you mean by congenital nephritic syndrome? Then I'll go on to all those elderly and all. What is congenital nephrotic syndrome? Now, I understood congenital means I have a lot of genes in front of me, but what exactly are these genes that we've written? I want all of you to go back to the first slide. Remember, I gave you the diagram of a podocyte and I said this will come to you handy one day. For example, this is one podocyte. Can you recall that diagram for me? Which was the protein that was present on the outside? The only protein putting its head outside was nephrin, because there was a similar protein coming inside and that was Podosin. Everyone, have you been able to recall this? There was nephrin on the outside, there was podosin on the inside. Attached to the podosin was a round structure called CD2AP, and attached to this were all the filaments which we called as actin filaments. So 4 things we studied. The nephrin on the outside, then we studied the podosin on the inside, CD2AP, and the actin filaments, because now if these go wrong, this means the patient can have some problem. So look at this. The nephrin goes wrong means what? Can you see that there are 2 genes that are written over here? NPHS1 and NPHS2. So first know their full form, because as I say NP, it is NPH is nephrotic, NPH and S is syndrome. So these are the nephrotic syndrome gene. NPHS1 you can learn if you want to. It's on chromosome 19 and NPHS2 is on chromosome 1. But their chromosomes are not important. Honestly telling you, their chromosomes are not important. Their proteins are important. NPHS1 gene makes which protein? Nephrin protein. And NPHS2 gene makes podosin protein. And how am I going to learn this information? So have a look at the names. When you say NPHS1, the first alphabet, if you'll take out NPHS1, first alphabet is N. So obviously the first alphabet, that is N, will give you nephrin. Whereas if you take NPHS2, you take the second alphabet. The second alphabet in NPHS2 is podosin, P. So NPHS1, N, nephrin. NPHS2, P, podosin. Okay, what are they going to cause? Please remember, if there is a defect in this, it causes congenital nephrotic syndrome of the Finnish type. Congenital nephrotic syndrome of the Finnish type. When there's a problem in NPHS2, it causes autosomal recessive type of FSGS. Now comes something called alpha-actinin 4. Alpha-actinin 4 is telling me only that, yeah, this gene is going to code for actin. The name is only telling me alpha-actinin 4 will code for all those, the actin proteins. Yes. What does this cause? This causes autosomal dominant type of FSGS. We are writing it down. Don't feel that is ma'am going to leave us on our own to learn this and not going to give us any mnemonics? Of course I will, you when the right time comes. Next, if CD2AP gene is mutated, finally I don't have any mnemonic for this because there is no disease. I don't have any disease when CD2AP gene is mutated. Then these 4 I had marked in that nephrin, podosin, CD2AP, actin. These we had marked. There are some miscellaneous genes also that can be defective. So please remember, if there is TRPC6 gene mutation, it results in adult onset FSGS, and if there is an ApoL1 gene polymorphism, that has been seen associated with HIVAN, that is HIV associated nephropathy. So these might not ideally be the congenital varieties, but only for completing your your genetics, I have put them up over here. Under congenital variety, obviously these are the ones that you guys have to know. Now, well, having said that, how am I going to make you learn it? Obviously I'm not going to leave you somewhere in the in this ocean on your own. So सबसे पहले, everyone, have you learned the genes and their proteins? CD2AP I don't have to worry about, भूल जाओ. Actin is telling me actin protein. NPHS1 is telling me nephrin. NPHS2 second alphabet is telling me podosin. The proteins I have learned. I just have to know about the diseases. NPHS1, the first to finish the race. So remember, this causes congenital syndrome of the Finnish type. Then out of NPHS2 and alpha-actinin 4, I realize both of them cause FSGS. One is dominant, one is recessive. So there are 2 ways of learning it. This is a problem in podosin. Podosin wala problem hai, that is autosomal recessive variety. Or you can learn alpha-actinin 4, and 4 is nothing but the 4th alphabet D, A, B, C, D. So that is the autosomal dominant variety. Whatever mnemonic works for you. Podosin wala PR, that is autosomal recessive FSGS. Alpha-actinin 4 is A, B, C, D, D, it's autosomal dominant FSGS. So like I told you, I'm not going to leave you alone in this journey. We have finished the congenital nephrotic syndromes also over here. So coming all the way back, You've done the childhood, minimal change. You've done the adult version, FSGS. You have now finished the extremely young congenital variety. Now let's go on to the right end of the spectrum. What is the one most common that you have in elderly? And that was membranous glomerulonephropathy. Having said that, you see a lot of causes written in front of you. How will I learn this? First, guys, try to understand what is the disease, because that will give you a little bit ease. When we talk about membranous, and then glomerulonephropathy is obvious, but membranous will tell me that ultimately there is a thickened membrane that is going to be there. Ultimately, there is a thickened membrane that is going to be present. So there's a membranous involvement. Having said that, which membrane am I talking about? Of course, I'm talking about the basement membrane. There is only one membrane that I have. So how is the basement membrane becoming thick? There are some kind of antigen, antibody, whatever may be the reason, some kind of antigen, antibody reaction that is happening. And you know, where is that happening? First, I'm going to go in this disease, I'm going to go a little opposite. I'll tell you the entire pathology part first, and then I'll come back to the causes, okay? Because that will give you better understanding. You need to understand first, why is the membrane becoming thick? Why is this basement membrane becoming thick over here? So please remember, I'll start from right end. There are subepithelial deposits. What do we mean by subepithelial? Whenever I show you a black and white picture, whom do you have to catch? Find the foot. Find the foot processes, guys. That's your job right now. Find the foot processes. Can we all see this and these as foot processes? Yes. So this must be the visceral epithelial side, and this must be the red blood cell wala. These must be the endothelial cells. So that is the outer side. This is the inner side. I've understood that, okay, this must be a capillary loop like this. This must be a capillary loop. This side is all the blood, that side are all the feet. And I realize that below the feet, I have some complexes which are sitting. Means below the feet, subepithelial deposits is what we notice. We see the presence of subepithelial deposits. I hope that is the first thing that you've understood, because now I'm going to draw it out. The first innermost layer that you guys had was what? The endothelium. Right now, I'm not interested too much in the endothelial layer. After that, the next that you have in order over here is going to be the basement membrane. After that, you have, I'd always told you, find the feet. So here you have the feet over here. These are going to be the podocytes or the visceral epithelial cells. Where are the deposits occurring? Let's make pink color deposits. Where are they? They are occurring over here, over here. These are basically occurring on the subepithelial region. Now just tell me one thing. These immune complexes, I'll write them as immune complexes. They are coming and sitting where? In the subepithelial region. Basically, they are coming and sitting on the basement membrane. Will this basement membrane tolerate? This is the basement membrane, and I put a big burden on top of it. After some time, the basement membrane will say, what the hell is this? Take it out. Why have you put this big burden on top of me? So this basement membrane starts reacting. The basement membrane says, what is this? How can you just come and put something on top of me? I am going to speak up. I am going to speak up, and this issue will be raised to the higher authorities. How can you keep an immune complex on me? Can you see what the basement membrane has done? It has sent out spikes. Initially, it says, okay, I will raise my voice. It has raised multiple voices. Listen to that. And if you don't take that burden off, what will the basement membrane do? Total rebel. All these things that it has raised, it will fuse. All those raised voices will come together. Can you see what has happened? This will all become like a very thick membrane. This entire region, the basement membrane coming, it will engulf everything and make an extremely thick membrane over here. So let's repeat what has happened. Initially, the basement membrane said that you have put such a burden on top of me. I am going to come up like this. I'm going to come up like raised voices. These raised voices are known as spikes. Because now I'm going to tell you what is the spike and dome pattern. These raised voices, these are known as spikes. So spikes are nothing but the basement membrane. And where is the dome? That immune complex is a dome. So remember, can you now see? There's a dome and then a spike. then dome, spike. Spike and dome pattern has come. Spike is the basement membrane, the voice going up, and then the dome, then the spike, then the dome, then the spike, then the dome. That is the spike and dome pattern. And after some time, the basement membrane says, if you're not listening to me, all these spikes are going to come together. All these are going to come together, and this is then going to become one thick membrane. So now you understand why did I start the story as thickened basement membrane. Now I can explain everything to you. So the first thing that I show you in membranous glomerulonephropathy is a thickened basement membrane. I show that to you from the usual light microscopy. Look at the basement membrane. Earlier I used to draw such thin capillaries. Now look what has happened. The basement membrane is showing me such a thick capillary loop. It's showing me such a thick capillary loop because the basement membrane is thickened. So number one, you see a thick basement membrane. Then you look at electron microscope. I've already told you this is below the feet. So subepithelial deposits are going to be there. But are you waiting to see that spike and dome pattern? Yes. So remember the spike and dome pattern ke liye, can you repeat with me? What was the spike? Who is making the spike? The spike is being made by the basement membrane. And who is making the dome out here? The dome was nothing but the immune complex. So now just imagine, go back to the first part of the chapter, and I taught you that if you want to identify the basement membrane, is there a special stain, a blackish color stain that you can use? For the basement membrane, had we studied Gomori's methenamine silver stain can be used. Silver will always be black, na? So now if you look at this picture, you realize that the basement membranes are coming out black. Why are the basement membranes coming out black? Because I have used Gomori methenamine silver stain. And now also, like boys used to, once upon a time it was quite trendy, boys used to have that spiky hairstyle. Yes, everyone in college and school used to have that spiky hairstyle. Can you see how this black color has sent spikes? You can see so many of them, how black color is sending out spikes. What is black color? Black color is basement membrane, and I know from my pathogenesis that yes, the black color will send out spikes. So I can finally see the spike and dome pattern. All the things that I studied are coming in one place. First, I saw the deposits for subepithelial. After that, I saw the same thing under the electron microscope. Then the basement membrane started reacting. It started showing you spike and dome pattern that I can see on a Gomori methenamine silver, and because of all of this, the membrane becomes very, very thickened. Now, having discussed the entire pathogenesis, I can come back to the things that I have to mug up. Membranous glomerulonephropathy, like I told you, is the most common nephrotic that you have in two situations, that you have in elderly and you have in cancers, because old people usually have cancers. Usually, if I go by the rule, old people have cancer. So having said that, how I have learnt it is that this is the disease that shows you spiky pattern. Wo spiky wala pattern means it shows you the peak pattern, and it is seen at the peak of the age. That's how I have learnt it. Membranous glomerulonephropathy shows you a spiky pattern, so peak pattern, and is seen at the peak of the age where cancers occur. Easy to learn. Now, what are the causes? It can be primary, which earlier was said that we don't know the cause, but then later on studies were done and they found the cause. So there's primary and then there is secondary. So I wish I could tell you it's just idiopathic and run away from it, but now they know the cause and there's an update. There's a Robbins 10th edition update, so you have to listen to me super carefully. What was known since many, many years is that there are some antibodies against the PLA2 receptors. Phospholipase A2 receptors, and those are responsible for this. In fact, I'll tell you something very interesting. Where are PLA2 receptors present? PLA2 receptors are present in the human kidney. Na? They also ask you that when in membranous glomerulonephropathy, that is a disease when there are antibodies present against which antigen? Against PLA2 receptor antigen. So that is what they talk about, humans. Whereas then they wanted to ask you about rats and mice. I don't know why they want you to study about the kidneys of a rat or a mice. But then they said that there is something very similar in human models known as Hayman nephritis. See, it has the word man, but it's not in man. Hayman nephritis, and that is similar to this because in that the antibodies are against an antigen called a Megalin antigen. So this is another thing that they want to tell you when it comes to animals. Tiny cute animal I have drawn. So it looks like hey man, but it's not man. It is to do with animals. And they said like in humans you have antibodies against phospholipase A2 receptors. In animals you have antibodies against the megalin antigen, and that megalin antigen is going to be hey man nephritis. Sorry for making you learn about other animals and their kidneys. So let us come back to human kidney. So like I said, there are antibodies against the phospholipase A2 receptor. This I know since decades, nothing new. What is new and what is the update is antibodies against thrombospondin and antibodies against CD10, and they have been associated with what? Right now I told you this is a disease in the old people, 60 and above. Now I'm saying this is associated with neonatal membranous glomerulonephropathy. Antibodies against thrombospondin and CD10 neutral endopeptidase. These were all antibody primary causes. Now coming to the secondary causes. Under secondary, please remember you have the usual. If I ask you what is under secondary, you will say the entire Harrison is under secondary. Harrison is what? Harrison is reading about medicine is what? Reading about infections, reading about cancers, reading about diseases like diabetes, SLE, and finally reading about their treatment. So the entire medicine can probably come under this. Now coming back. So when we are talking about drugs, you have drugs, for example, gold, NSAIDs, penicillamines, gold, NSAIDs, penicillamines, number one. Cancers, so many cancers can lead to this. Colon cancer, lung cancer and melanoma are their favorite questions in the paper. In systemic diseases, they put up the most famous diabetes mellitus and SLE. But in infections, I know all of you have been waiting for infections. There's a long list. Out of that long list, I have selected 6. Usually we have a habit, whenever someone gives us a list, we try to shunt out that list and make a shorter list. Now let me tell you, I've done that aspect. So I'll give you 6 organisms. Do not make it shorter than that, okay? So what are the 6 organisms? First, we'll start with the H and H, that is hepatitis B virus and hepatitis C virus. Then I'll start with the S and S, that is syphilis and schistosoma. Syphilis and schistosoma, and finally malaria and leprosy. So again, like I said, this is already a concised list. Don't select out of it. Repeating, the 2 hepatitis, B and C, then SNS, that is syphilis and schistosoma, and finally malaria and leprosy. These show you membranous glomerulonephropathy. I hope everyone's understood. Or a disease that occurs in the peak of the age and shows you a peak pattern. But for neonatal, now you have antibodies against thrombospondin and CD10. Now, having discussed this, we move on to the last part of this, that is MPGN. Now, why did I keep MPGN for the end before I start telling you all this theory and all? There's a reason why I kept it in the end. First, let me write the full form, because maybe then you will be able to agree with me that I did the right thing by teaching you in the end. Membranoproliferative glomerulonephritis. Membranoproliferative glomerulonephritis, and that basically means is that it has a membrano part, like there was MGN. So you will say that, yeah, there is a thickened membrane. Okay, this is just like MGN, thickened membrane is there. But there is a proliferation part also. Now, just think, where did I teach you? Which disease I told you that there's a lot of proliferation? The cells are proliferating. What disease was it? Acute proliferative glomerulonephritis was post-streptococcal glomerulonephritis. So I can now actually see that this is coming across as a combination. It has little bit features of MGN, which is a nephrotic syndrome, and it has little bit features of PSGN, which was a nephritic syndrome. And that is why I'm teaching this to you right in the end, because this is a combo glomerulonephritis. This is a condition which can show you overlapping features of nephrotic. Repeating, the name only tells me. Membrano word tells me that it has a thickened membrane like membranous, so that is nephrotic. Proliferative word tells me it has a lot of proliferation similar to PSGN, so that is going to be nephritic. It's a combo, but if you have to select one, the reason that I'm teaching you in this segment is it shows you more of nephrotic. So if you have an option of both, that will be your best answer. Otherwise, you go for nephrotic. Now let's go into a little bit more details about it. This happens because of two conditions, or you can say two types, because there's an update. Just not writing it because I don't want to confuse you. Earlier there were 3 MPGNs, MPGN 1, 2 and 3. Now there are just 2 MPGNs and their names have changed. Now go by the latest. There are only 2 MPGNs. This is something called MPGN type 1 and then there is something called MPGN type 2. Forget the 3. There is no 3 any longer. If you have it in any of your old books, do not read that. So what is MPGN type 1? Usual. It can either be primary, good for me, I don't know the cause, or it can be secondary. And what all do I have in secondary? We have alpha-1 antitrypsin deficiency can result in it. Hepatitis B can result in it. Again, hepatitis C and B are coming. Other than that, we have schistosoma that can cause it, cryoglobulinemia that can cause it, and CLL that can cause it. Why did I write it again? Because I wanted to tell you that I have written it in a particular order. Also guys, HIV can also result in MPGN. HIV can also result, although I told you HIVAN is most commonly to do with FSGS, but HIV can also cause this. So if you realize, we have A, B, C, schistosoma sounds like a C, cryoglobulinemia and CLL. So A, B, C, 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 all these causes are coming together, and this CLL wala question causing MPGN, very important. Alpha-1 antitrypsin causing MPGN, very important. So repeating once again guys, we have alpha-1 antitrypsin deficiency, hepatitis B, hepatitis C, schistosoma, cryoglobulinemia and CLL. In fact, let me tell you once again, for hepatitis C, they definitely ask you this question, because hepatitis C, I was teaching you in a lot of places. So I'll be telling you which of them causes what eventually, but this is for MPGN1. And now I can tell you what will MPGN1 show you under the microscope. So firstly, it shows you the very famous tram track appearance. What is this tram track? You can see the basement membrane. Firstly, basement membrane is looking very, very pink. What is the pink color basement membrane stain that I use? They've used PAS, and they saw the basement membrane is split everywhere into 2 parts, just like a railway track. Just like a railway track, it is split up. So there is actually a splitting of the basement membrane that you notice over here. Splitting of the basement membrane that you notice over here. So now they will ask you, why did that happen? Okay, so please remember, I'm going to draw that famous diagram of ours. What is this? This is the endothelial cell. Okay, what is above it? All of us know above it we have the very, very famous glomerular basement membrane, and finally on the top we have everyone's favorite foot processes or visceral epithelial or podocytes. Yes, we all know this diagram. Do you know in MPGN type 1 the deposition occurs over here? That is subendothelial. The deposition is going to occur in a subendothelial manner. Someone is sitting over here below the endothelium. One cell gets suddenly very angry. That why is this cell sitting over here? Why is this cell sitting over here? The mesangial cells. The mesangial cells become very, very angry. Mesangial cells were what? Mesangial cells were macrophages. Mesangial cells become very, very angry and they say, how can you sit like this? They will say, wait, we are going to come. An army of mesangial cells will come and take it out. An army of mesangial cells will come, take it out. An army of mesangial cells will come and take it out. But remember, is it so easy? Repeating, is it so easy to just remove the immune complex? No. When this army will come and take it out, has it split a little bit of the basement membrane? Will the basement membrane also get pulled in that manner? Yes, someone is, for example, this was my basement membrane, my hands. This is the basement membrane. Someone is trying to pull this left hand of mine. If someone is trying to pull it, obviously my 2 hands will get separated, and that is what has happened. The mesangial cells are coming and separating it out, so the basement membrane ends up getting split, and that is the reason for splitting of the basement membrane, which tells you one more thing. This is somewhere having a role of mesangial cells. So that is the reason that membranoproliferative glomerulonephritis is also known as mesangiocapillary glomerulonephritis. This is also known as mesangiocapillary glomerulonephritis. Nephritis. I hope that is clear. You've understood how the mesangial cells or the macrophages are coming and they are taking out the immune complex from that area and the basement membrane is splitting out. Having said that, this is the tram track or the railway track appearance that has happened. This was all about MPGN type 1. Now let's go on to the recent most update, MPGN type 2. So simple, I'll tell you a story. It's my favorite most because it has no causes. It is a single disease, single cause. They did blood tests of patients with MPGN type 2 and they found all of them had something in their blood called C3 nephritic factor. They are born with it, they will die with it. So they all have a thing in their blood called C3 nephritic factor. C3 means it is going to affect the complement system, which means it binds to C3 convertase and activates constantly. C3 convertase will convert what? C3 constantly. It is going and telling the C3, okay, get activated, constantly poking C3 all throughout the life. Can I say C3 will always keep on getting activated into C3A, C3B? Means eventually C3 levels will always be low. As soon as C3 levels come up, it is activated. Next time tries to come up, activated. So can I say forever the C3 levels will be low, there will be hypocomplementemia because all the time it is activated. Forever means there will be persistent hypocomplementemia because that is one of their most favorite questions. When I started off this journey of nephrotics and nephritics, I asked you, where do you see transient hypocomplementemia? Where do you see transient hypocomplementemia? You told me it was PSGN because PSGN was streptococcus related. Streptococcus will be there for 6 weeks. For that time, complement levels will go down. After that, streptococcus will go away. Everything will be fine. But here, these patients, like I told you, they are born with it, they die with it. They are always going to have this C3 nephritic factor. So the complement levels will always be decreased. Always remember, guys, persistent hypocomplementemia, you think of MPGN, and transient hypocomplementemia, you think of PSGN. And do you know which MPGN? MPGN type 2, because what are you also calling it? MPGN type 2 is known as DDD. What is DDD? It is the dense deposit disease. It is the dense deposit disease, and I think I don't even need to mark out. This is a black and white picture called electron microscope, so it has only two colors, black and white. What is dense? What is dense black? You can see there's a dense black color thing which is going all throughout. That's the basement membrane. So basically, whatever is going to get affected is going to be intramembranous deposit is going to occur. Intramembranous deposit is for MPGN type 2, which is DDDD. Moving on with the nephrotic syndromes, we now need to discuss the systemic disorders which are associated with it. So the first one of this is SLE, which you've studied in a lot of detail under the immunology chapter. And now we are going to go and discuss the SLE part of kidney. So the SLE part of kidney is referred to as lupus nephritis. It is referred to as lupus nephritis. Now, please remember there are many classes and this ranges from multiple classes of class 1 to 6. In fact, as per the latest updates, now they're even saying that 7 is going to come up. So these are different classes and you might get a little overwhelmed by looking at their names. We'll try to simplify them. You just have to keep advancing the disease. What do I mean by that? Starting from class 1, as you can go towards class 6, you will realize class 1 has everything minimal. There is minimal mesangial, LN means lupus nephritis, minimal mesangial lupus nephritis. So there's minimal mesangial involvement. In type 2, you will have to increase that. There is mesangial proliferation that is seen. So first two I think are sorted. In the first one, there is minimal involvement. In the next one, there is a little more proliferation. After that, you come to class 3 and class 4. How many of the glomeruli are getting affected? If less than 50% of glomeruli are getting affected, that is focal lupus nephritis. If more than 50% are getting affected, then that is diffuse lupus nephritis. So simple, I've divided it into groups of 2. The first 2 are to do with mesangial, minimal and proliferative. The next 2 are to do with percentage of glomeruli, less than 50, more than 50, less than 50 is focal, more than 50 is diffuse. And finally, class 5 and 6, 5 is when there is Membranous means the membrane is thickened, and 6 is the most advanced one when there is sclerosis that has happened. These are the 6 classes that you have, and now I can tell you, out of these, in class number 3, 4 and 5, we see one of the most characteristic lesions of SLE, that is the wire loop lesion. So remember, wire loop lesions, firstly I'll tell you in which classes do you see them. You see that in class 3, 4 and 5. But if someone asks you that in which class do you see maximum wire loop lesions, so see, wire has 4 alphabets, loop also has 4 alphabets. So the 4 number is seeming quite important here. So wire loop lesions are maximally seen in class 4. Right? Now, having said that, please remember, I'll show you this. It's the usual pink and blue slide for you. This means it's a light microscopy. The HNE slide has been shown. And can you see the capillary loops are looking a little thicker? At the peripheries, you can see something is looking a little more thicker. So it's like you take a wire and you fold it. That is said to be a wire loop lesion. And actually what it means from pathology point of view is, where has the deposition occurred? The deposition has occurred in the subendothelial region. What other thing was getting deposited? Because after a while I'm going to give you all a summary. What other thing is deposited in the subendothelial region? So remember, subendothelial is only 2 things. One of it is SLE, that is the wire loop lesion, and the other one was MPGN type 1. MPGN type 1 was also subendothelial. We'll make a summary of all these locations in the end. Okay, this is what you see on light microscope. What do you see on electron microscope? If I look at this wire loop lesion, this wire, I look at it under the black and white. Remember, on electron microscope, that wire is going to look like a thumbprint. It's going to look like a nice forensic thumbprint. So that is the appearance of the same wire loop under electron microscope. Which microscope am I left with? Immunofluorescence. Immunofluorescence tends to show you a full house effect. What is the meaning of full house? You will say that I can see, obviously immunofluorescence hai, I can see all the green color like we always see. But full house means it's a full house party. Everyone has come and is getting deposited here. So what all antibodies? IgG will come and sit here, IgA will come and sit here, IgM will come and sit here. Not just antibodies. When I say full house party, everyone is invited. C1, C3, complement proteins are also going to get deposited. So all these come and get deposited in the kidney. All these come and get deposited in the kidney. That is known as the full house effect. So now if I have to go back and give you a summary of what all will you see in lupus nephritis. In lupus nephritis, you will see SLE. Means what? There is a sign. Which sign? Or someone who doesn't know how to sign, what does that person do? Thumbprint. So there's a sign that is known as a thumbprint that you see in case of SLE on electron microscope. What do you see on a light microscope? You see loops. You see loops on a light microscope. So we see the very famous wire loop lesion. Finally, where is everyone getting together? Everyone is getting together for a house party. So remember, we see something known as a full house effect. What effect do we see? An effect called full house effect on immunofluorescence. These are the 3 points about SLE. You see a sign, or someone who doesn't know how to sign puts a thumbprint. So thumbprint sign, wire loop lesion, and you see everyone parting. So full house effect. That is for lupus nephritis, total 6 classes. Having studied lupus nephritis, the next and one of the most important systemic diseases causing nephrotic syndrome is diabetes mellitus. So when diabetes mellitus occurs in the kidney, what do you call it? The name of the topic becomes diabetes in the kidney is the diabetic nephropathy. So you will now see a long list of things that happens with diabetes in the kidney. So the mnemonic is also going to be the diabetic nephropathy. If you learn the diabetic nephropathy, you've learned all the changes, because now I'm going to show you a long list of changes that you have to know. Diabetes in the kidney, like we said, it is the diabetic nephropathy. See? Easy mnemonic. Let's start. What is happening to the basement membrane? There is thickening. T for there is thickening of the capillary basement membrane. What is H? H we have studied. If you go back to your vascular chapter, you have studied H as hyaline arteriolosclerosis. Hyaline arteriolosclerosis has been studied. If you remember, hyaline arteriolosclerosis was seen in two conditions. It was seen in benign hypertension and it was seen in diabetes mellitus. So T for basement membrane being thickened, capillaries, H for hyaline arteriolosclerosis. So basically both of these are blood vessel problems. Comes the E, Armani-Epstein lesion. Quite a fancy and quite a branded name, na? Armani-Epstein lesion. So tell me, can you buy brands at the age of 15 or 20? These brands are really expensive. So you have to work very hard in life and you have to earn a lot of money to be able to buy that brand. So you will be able to do that at a very later stage. You can't do it early on in life. Why am I telling you this story and making you feel bad that you will get Armani at a very late stage? Because Armani-Epstein lesion is not an early change in diabetes. It's one of the late manifestations. And what is Armani-Epstein lesion? So Armani brand is something known as glycogen. There is glycogen deposition that occurs in which part of the kidney? That occurs in proximal convoluted tubule. Let me remind you of these two PCT things that I have in this chapter. In proximal convoluted tubule, like I told you, in one place lipid is getting deposited. Remember lipoid nephrosis, minimal change disease, lipoid nephrosis. Now I'm telling you glycogen is getting deposited and that is a situation known as diabetes mellitus. And this glycogen in the PCT is referred to as this Armani-Epstein lesion. You'll have to wait a lot in life to earn a lot of money to buy this brand. So yes, it's a late manifestation. What next? We have glomerulosclerosis happening. I've already taught you the meaning of glomerulosclerosis. So D and N, one is diffuse glomerulosclerosis, one is nodular glomerulosclerosis. Let me first explain that. Diffuse means everywhere. What is this nodular? Have a look at this. This is what you call as NGS, nodular glomerulosclerosis, which means that there will be a picture of a glomerulus which I can very well visualize over here, and there is going to be some nodularity that I will notice. Nodularity of what? Sclerosis. Sclerosis is pink material. So I can very well visualize there is pink color material here, there is pink color here, pink color here, pink color here. There are multiple pink color lesions that are basically going to be present in a case of nodular glomerulosclerosis, and this is also known as the Kimmelstein-Wilson lesion. This is also referred to as the Kimmelstein-Wilson lesion. And why am I spending so much of time on it? Two questions. Firstly, what is that pink nodule formation? So what is that? These are all non-enzymatic glycosylated products. These are all non-enzymatic glycosylated end products, which you know is one of the major findings that happens in diabetes. In diabetes, there is glycosylation, right? There's a non-enzymatic glycosylation. So these are all the products. Question number 2, this is the most characteristic lesion of diabetes mellitus in the kidney. This is the most characteristic out of all the full mnemonic that I taught you. And question number 3, this is PAS positive, which they shall ask you in the form of an MCQ. They will show you this lesion, they'll give you a history of diabetes, and they will ask you what is the stain that you should be putting. So you should be putting that pink color stain, which is known as PAS. So coming back, KW lesion or Kimmelstein-Wilson lesion, known as nodular glomerulosclerosis, because everything is in nodules. What is that pink material? They are glycosylated end products. This is the most characteristic lesion, positive for PAS. When it is in nodules, I call it nodular. If it would have been everywhere, I would have called it diffuse. So D for diffuse glomerulosclerosis, N for nodular. Nodular known as the KW lesion, which is the most characteristic lesion. Having said that, what is other things for D and N? Drop and cap. What is drop and cap? You're not going to get a picture for it, but just remember, now I show you the same glomerulus, the same glycosylated end products. If they end up making a drop over here, they are dropping from the Bowman's capsule. If it drops from the Bowman's capsule, I call it capsular drop. If it drops from the Bowman's capsule like that, it is a capsular drop. If it would have been sitting over here on the capillaries like a cap, If these end products that you're talking about, these pink products, they sit on the capillaries like a cap, I call it fibrin cap. Then it is referred to as a fibrin cap. So there's something called drop and cap that you have to know with D. What is the last thing with N that you have to know? With N you have papillary necrosis. Necrosis you all understand. Necrosis is death. What is papillary? Renal papilla. Renal papilla is going to die. So there is a renal papillary necrosis that has occurred. So let's repeat. What is the diabetic nephropathy? T and H are for blood vessel problems. There is thickening of the basement membrane. There is H for hyaline arteriolosclerosis. E for a late lesion, Epstein lesion, and the branded Armani-Epstein lesion. Glycogen in the PCT. Coming to the next, D and N, diffuse glomerulosclerosis, nodular glomerulosclerosis. Nodular was KW lesion, most characteristic. Other things with D and N, drop and cap is with D, and N for papillary necrosis. However, I want to ask all of you a question. Renal papillary necrosis is seen in a lot of other places also that you are going to tell me. So quickly let me know, guys, what are all the situations in which you see renal papillary necrosis? And there's a very famous mnemonic, so I leave that to you. What do you like? Do you like soda more or you like dosa more? So for example, you say you like dosa more, okay? So what are the causes of renal papillary necrosis? Number 1, diabetes mellitus. Next, if there is any obstruction to the kidney, so obstructive pyelonephritis, or there is some obstruction that is present. S for sickle cell anemia, and A for analgesic abuse or analgesic overdose. So this is obviously a very famous question. These two specially are very famous. So DOSA, diabetes, obstruction, sickle cell, and analgesic overuse. These are the ones which are going to kill the kidney papilla, renal papillary necrosis. However, the most common cause is what you're reading over here, and that is diabetes mellitus. I hope everyone's okay with it and there's no confusion going forward. Having discussed all these diseases, it's time for the summary that you guys have been waiting for. So I have a glomerular and an entire glomerulus is drawn in front of you. We just have to look at which part is going to show me which deposition. So let me start off with the easiest one over here. Do you all remember? Let's start from the nephritics. From the nephritics, if you remember, there was PSGN in kids and there was adults showing you IgA nephropathy, right? So where was PSGN? PSGN was showing you that mountain, subepithelial humps. So here you go, you have to talk about something below the epithelium, means something below the foot processes. So number 1, when we talk about a subepithelial kind of a deposit, the first thing coming to my mind is PSGN. This was in the nephritics, but if you remember, in the nephrotics, even membranous glomerulonephropathy was showing you subepithelial deposits. So basically, for subepithelial, you have picked up one in the kids, one from nephritic, one from nephrotic, one in kids, one in adults. Simple, you've touched upon all categories. So for subepithelial, you've picked up one in nephritic and kids, that is PSGN, and one in elderly and in nephrotic, so you've picked up membranous. After that, you talk about what is going to be there in the mesangium. So I told you how to learn the mesangium. Mesangium is there in the middle. It's somewhere in the middle. It's somewhere in between. So in between, we had studied, we will have Berger's disease. Berger's was which antibody? Berger's was IgA nephropathy. What are we left with? Where are we going to have deposits? In the membrane. In the membrane basically means basement membrane. So where are we going to have intramembranous deposits? Where are we going to have intramembranous? If you remember, there was a disease called dense deposit disease, DDD, which is going to be MPGN type 2. MPGN type 2. Finally, the last one, where you're seeing below the capillaries, means you are seeing subendothelial deposits. Subendothelial deposits are seen in MPGN type 1, and it is seen in wire loop lesions, which you see in SLE. They were also subendothelial. This is going to be your final flashcard, which is going to help you ace every question regarding depositions in the exam. Let's pick up. When you're talking about subepithelial, you have one in kids and one in elderly. So PSGN and MGN. Berger's is very simple. Berger's is somewhere in the middle between. So that is going to be mesangium. When we talk about intramembranous, there is only one one, the dense deposit disease, intramembranous, that is DDD, MPGN type 2. And then whatever you are left with, subendothelial, the least that we studied, MPGN type 1, and the via lobe lesions. With which we have studied this summary. There is one more summary that I want to tell you, which a lot of students ask me, is regarding hepatitis C virus. And they say that what is the most common thing that hepatitis C virus causes? Because I gave you hepatitis C in the causes of membranous glomerulonephropathy. But just in case you have cryoglobulinemia, in fact. If this is there, because HCV is very commonly associated with cryoglobulinemia. If this is there, then this is obviously a more common kidney problem with hepatitis C than membranous. This is just another summary that I'm telling you. So if they say HCV is associated with cryoglobulinemia and glomerulonephropathy, and then MGN is also there, select cryo over MGN. With all these summaries done, I think we are ready for some set of questions. Where do you see the presence of HEVAN? HEVAN is associated with what? I hope you all remember. HEVAN was associated with FSGS, focal segmental glomerulosclerosis. But if I now ask you that HEVAN is associated with which type of FSGS? Remember, HIV is a bad disease, so the bad one had to come up. The bad one was the collapsing FSGS. Do you remember what classification was this? This was the Columbian classification. This was the Columbian classification of FSGS, which taught me that there is an NOS type of FSGS, which is the most common. There is a glomerular tip type, which has the best prognosis, and there is a collapsing type, which has the worst prognosis, and that is what you see in HIV patients. Moving on to the next question. Which of the following signs and symptoms is common in minimal change disease? Minimal change, remember, there was something very selective about it. Selective proteinuria was happening. Even if you look at the other things, I know minimal change disease is a nephrotic syndrome. It's a nephrotic syndrome. And what I'm seeing otherwise is the HOHA mnemonic of nephritic syndrome. I'm seeing hypertension, I'm seeing hematuria, I'm seeing azotemia. These were features of nephritic. I can't have nephritic when I'm talking about minimal change disease. Minimal is nephrotic, so selective proteinuria is the answer over here. Let's pick up the next question. If present on kidney biopsy, which variant of focal segmental glomerulosclerosis has a significantly poorer prognosis and supersedes the presence of others if other variants are also present? What a complicated way of asking you a simple question, that which type of FSGS has the worst prognosis, and if others are present, even then this is going to be the worst of them all. I think we already know it's the collapsing variant. So how, instead of a one-liner that which is the worst prognosis FSGS, how they made such a complicated English sentence out of it? But I think we are sorted. Our basic concept is collapsing is the worst. Coming to the last question of this segment. There's a 6-year-old male child with frothy urine. And I've been kind to you, I've written it in bold. Okay, so there's a child with frothy urine and edema. Urine examination report has been attached herewith. Let's read it. Appearance is frothy. We don't see any RBCs. WBCs are not there. Epithelial cells are not there. Cast, I told you, 0-1 hyaline cast is hardly anything. Crystals are not there. Protein, massive proteinuria is definitely. 3+ means there is massive proteinuria. And that is obvious because the urine appearance was also frothy and the patient was also having edema. So this much is certain that I'm dealing with a nephrotic syndrome. And if I think logically of a nephrotic syndrome in a 6-year-old male child, I am thinking of minimal change disease in my mind up till now. Then they do serum protein SPEP, serum protein electrophoresis. If you can see carefully, the albumin level has gone down. Albumin level, as we see over here, has gone down, and this A2, alpha 2 levels are more. Did I teach you this SPEP and I told you that this is classical history of a nephrotic syndrome, and anyway from my history I know it's nephrotic. Which out of these is nephrotic syndrome? I know RPGN is nephritic, good pasture is nephritic, ruled out. Nephrotic are these two, but I have a kid in front of me. But not just that. Histopathological examination reveals no obvious abnormality, minimal change. If it would have been FSGS, it would have been showing you focal and segmental and glomerulosclerosis, so many things. It's not showing you anything. It's definitely a case. The age is going, the histopath is going. It's definitely a case of a minimal change disease. Although I said it was the last question, but I have one more question that I want all of you to attempt, which is from medicine actually, where you have a 55-year-old female who comes to a health checkup to a path lab, and her CBC findings are hemoglobin is good 12 grams, TLC 10,000, anything up till 11,000 is good, DLC also seems to be fine, platelet count 1,70,000, anything above 1,50,000 is good. So up till now she seems healthy. But then comes her HbA1c level, which is an 11%. Of course, she is having diabetes, and that too uncontrolled diabetes. Urine examination shows protein 2+, glucose 3+. I'm very, very sure urine glycosuria is also happening. Glucose is coming out into the urine. Renal biopsy shown below. Can you identify this picture? It's showing you the classical nodular glomerulosclerosis or KW lesion. They've asked you now a pathology question out of it. What is the special stain? I taught you that the special stain for KW lesion is the PAS positivity that you have. With which we wrap up our entire discussion of nephritics and nephrotics. I know it's a tough part, but I hope you've managed to gain some confidence out of it. What we'll be starting with next are the renal tumors.